Good afternoon, everyone. iTech India welcomes all the participants for today's Regional Distance Learning Seminar Series. Today's topic is Advanced Disease Management in CLHIV less than 5 years of age, and the speaker is Dr. Sucheta Munshi. Dr. Sucheta Munshi ma'am is a Senior Associate Professor with the Department of Pediatrics at BJ Medical College and Civil Hospital, Ahmedabad. She is a National Faculty for Neonatal Resuscitation Program, FBNC, and various other national programs. She has multiple paper publications to her credit, and apart from HIV, has a special interest in neonatology and hematology. We welcome you, ma'am, for today's session and request you to start the session.
Good afternoon to all. I thank you for this opportunity, and I'm glad to be communicating with you on this topic. Today we will be discussing the advanced disease management in children living with HIV less than 5 years of age. Now the question is, why have we selected this age group and why we are offering them advanced disease management? Now, we would like to also discuss on the major causes of morbidity and mortality in CLHIV, the package of advanced disease management under 5 years of age, and with special emphasis on tuberculosis in CLHIV, because as we know that co-infection with tuberculosis is very common, and it contributes very significantly to all the morbidities and mortalities in CLHIV. Now, this is important, less than 5 years, because it has been found that the morbidities and mortalities are very high in this age group. Again, they are a particularly vulnerable age group because we have seen that even routinely, even in the absence of CLHIV, they are very much susceptible in a third world country like ours or a developing country like ours to various morbidities and infections. Now, this situation is further very much complicated when they have a co-infection with HIV, and many of them come from a social situation which further adds and augments and intensifies this problem. Now, what do we mean? We have clubbed by all these children less than 5 years, and they have been considered as having advanced disease. So what do we mean by advanced disease? We shall be discussing, and why. So all children who are less than 5 years of age, who are not already, all children less than 5 years of age are considered to have advanced immunosuppression and advanced disease, and they are clubbed together in this group. That is, they are said to have advanced disease. Now, only those children who are more than 2 years of age and who are absolutely clinically stable are not clubbed under this group. Apart from that, all children who are less than 5 years of age are considered to have advanced disease. Now, why? Like I said, we have to be clear as to why we are doing this. This is because it is found that the mortality is extremely high in this age group. It is 28.2% in all children less than 5 years of age overall, 38.6% in those having advanced WHO clinical staging, 35.2% with who are severely immunosuppressed, and 22.3% in the severely malnourished group. So advanced disease, like I have said earlier, is all newly diagnosed CLHIV aged less than 5 years of age. Apart from this, we also consider advanced disease in all those CLHIVs who have severe immunosuppression following treatment failure, or if they are re-engaging with the care after treatment interruption for any cause. Now, it is to be noted, like I have said earlier, that children older than 2 years, if they are stable and they have been taking ART for more than 1 year, are not considered in this age group of having advanced disease. Now, what are the common infections that we find in this age group? We have pneumonias. Even otherwise, even if the children are not having CLHIV, their common infections are pneumonia, tuberculosis, sepsis, and bloodstream infections. Diarrhea is very common in this age group, and severe acute malnutrition. And in the presence of HIV, all these problems are increased. Pneumonia is, when we consider it in a child less than 5 years, we also have to consider the possibility of PCP pneumonia in this age group. So normally in the community, we are taking care of, or we consider organisms like Staphylococcus, Streptococcus, Pneumococcus. And when we are dealing with an HIV, in addition to all these organisms, we also have to keep PCP in mind, especially when we are dealing with a child who is less than 1 year of age. Because as all of you are aware, there is a higher incidence and a very high mortality in infancy with PCP. Tuberculosis is a very significant problem. And not only can the child be suffering from tuberculosis, they could also be having an affected parent and family member who is having active tuberculosis in the family. And the child who is also HIV positive is very likely to suffer from it. And this leads to multiple problems, like it compromises the HIV, causes rapid progression, as well as tuberculosis per se is having a great impact on their nutrition, which further leads to a lot of clinical problems. So it is essential to be aware and to treat and screen these children for tuberculosis. Sepsis is again common as they are immunocompromised. The common infections are, as we see in other children also, like you have Staphylococcus, Streptococcus, and if they have been exposed to some hospital-acquired infections, then even gram-negative organisms are common. Diarrheal disease has always been a significant problem in our country. So this is also a very important contributor to the morbidity and even mortality. Malnutrition, particularly severe acute malnutrition, is something that we should always be aware of and screening the child. At the first contact, also the child has to be screened for SAM, as well as at every visit, the child's growth has to be monitored, as well as the child has to be screened for SAM or any growth faltering. So these features like pneumonia, including PCP, tuberculosis, sepsis, diarrheal diseases, and severe acute malnutrition. These are very major problems in this age group of less than 5 years, and therefore we have to be constantly vigilant, pick it up and treat it in time. So what is the incidence? So the incidence that has been found is a pneumonia. Just a second. Open, sorry. Just a second, please excuse us. So what are the major causes in India? Like we've said earlier, is pneumonia is including PCP is responsible for 38% mortality, which you can see is extremely high. Tuberculosis contributes directly and indirectly to a mortality of 28%, sepsis 20%, and other infections, including diarrheal diseases, at 10%. So we will now look at this package. Can change. So, like we said, they have to be offered the advanced disease package to all children. Has to be offered less than 5 years of age, have to be offered this. Now, the problem is, or let us say not problem, but the limitation is that no randomized control trial has been done specifically with children in mind. Now, as in the package, we have stop AIDS. That is the interventions that are offered to the children with in the advanced disease package. So stop AIDS stands for screen, treat, optimize, and prevent. So that is it is an acronym, and we should, whenever we analyze any patient, we should keep these four things in mind. That is the screen, treat, optimize, and prevent AIDS. So this is the technical brief of July 2020 with the package. So we will be taking up this box in greater detail as we go along. Now, stop AIDS. Now, screening. So which are the major diseases that we are screening for? Like we said, is that initially when any child comes to us, the first assessment that we do of a child is whether they are suffering from any serious disorder, because many of them would be coming to us already having some serious life-threatening illness. But after the initial assessment or the triaging of this patient for any life-threatening disorder, we would like to screen the patient for certain diseases. The first disease that we screen them for is tuberculosis. Now, there is a very well-defined algorithm which is present with the National Tuberculosis Elimination Program. And this has to be followed for the screening of these patients. We will again be taking up in detail in the subsequent slide. Cryptococcal infection is not that common in children who are less than 10 years of age. And therefore, unless there are certain very strong clinical pointers to cryptococcal infection, we do not advocate routine screening for cryptococcal organism in children less than 10 years of age. However, in the presence of advanced disease and severe immunosuppression, this screening is done in children who are more than 10 years of age. Malnutrition is an absolute must in all children. We cannot tackle the problem of HIV without tackling the problem of nutrition. So this is what we are screening the children from, apart from other things like any nutritional deficiencies, if they are having, as well as any other bacterial infections, because infections per se are more common in children who are having malnutrition. We aim to treat all opportunistic infections, tuberculosis, severe pneumonias, bacterial infections, and of course SAM, and all this treatment has to be done as per the national guidelines. We want to optimize their therapy after the initial assessment, screening, treating, and we want to initiate rapid antiretroviral therapy at the earliest or before discharge in hospitalized children, and we would like to optimize their regime such that their pill burden as well as the response is good. Antiretroviral therapy preparedness and adherence counseling is an absolute must in these children. Of course, we have to be aware that they are going to be taking it for a very long time, they're lifelong, as well as they are going to be dependent on their caretakers for the antiretroviral therapy as well as regular follow-up. And therefore, we would like to optimize this aspect also, that is the preparedness and adherence counseling. We also aim to start prophylaxis therapy as and when indicated, and we want to prevent bacterial infections, PCP pneumonia with the help of cotrimoxazole prophylaxis. Tuberculosis preventive treatment, that is IPT, is available for all children above the age of 1 year. And as and when indicated, we go in for cryptococcal prophylaxis against cryptococcal meningitis and secondary prophylaxis as and when indicated. We must not forget at any stage immunization as per the national immunization schedule. This is an absolute must, which plays a very important role in the prevention of many diseases. So not only should we emphasize immunization for the patient, as well as even the contacts and other family members should be taking their immunization as per the schedule. Routine interventions of childhood like supplementation with vitamin A, regular deworming, as well as supplementation with iron, multivitamins, and growth monitoring should not be forgotten at every stage. And nutritional counseling is an absolute must to prevent malnutrition. Now, when we first, the child comes to us, that is the first assessment is, we have to assess what is the condition of the child. That is the triaging of the child has to be done. Like there is an FIMNCI program that is the integrated management of childhood and disease infections. So under that, there is certain danger signs have been enlisted, which are coming under the red zone. So if any of these danger signs are present, then immediately the child has to be referred to an appropriate facility for admission, because it indicates that there is a very serious infection present. So this is the danger signs are, is the child able to drink or breastfeed? Is the child vomiting everything? Is there convulsions? Is the child lethargic or unconscious? And the presence of stridor in a calm child. So the presence of these 5 are danger signs, and this child requires immediate admission and or referral to a center and treatment where the child can be appropriately managed. In the absence of these danger signs, and even in these patients, after the initial triaging, we have to screen the child for severe acute malnutrition. Now, what are the WHO criteria for SAM? Severe acute malnutrition, we are calling SAM, as you all know. So first is edema of both the feet, or if the weight for height or length is less than 3 Z scores or 3 standard deviations for that age. So, or if the mid-upper arm circumference is less than 11.5 centimeters or 115 millimeters. Any one of these criteria makes the child qualify as having severe acute malnutrition. So in addition to any one of these criteria, if the child is having an additional feature like a medical complication, if the child is not having a good appetite and is not able to finish his ready-to-use therapeutic food, or has a problem with breastfeeding, then the child requires admission. If the child is not having any medical complication and has a good appetite, then this child may be followed up in the community with very close monitoring and very frequent visits. However, if any of the criteria for SAM are present, and in addition, there's a medical complication or the child's appetite is not good, it is an indication for immediate admission. Again, edema per se, if it is present, then the child has to be admitted. That is something we do not manage on a community basis. And that the child is suffering from some serious infection, and we would like to identify what is the system involved. So we look for certain additional signs which will tell us the disease that is present in this child. So we look for the presence of pneumonia. How do we pick up pneumonia? So the presence of fast breathing or subcostal, intercostal indrawing of the muscles, that is chest indrawing. Now, what do we define as fast breathing? So when the respiratory rate is 50 or more than 50 between the ages of 2 months to 12 years, or 40 or more than 40 between the ages of 1 to 5 years, then that is considered as fast breathing. So more than 50 between the ages of 2 months to 1 year, that is 12 months, And between 1 to 5 years, a rate of more than 40 is considered fast breathing. Chest indrawing may be present independent of fast breathing. So we have to look at both these parameters to decide if pneumonia is likely to be present. We look for severe dehydration. Now, what are the signs of severe dehydration? That is sunken eyes, sunken eyeballs, or when the skin pinch goes back very slowly. Now, what do we mean by very slowly? That is, if the skin pinch takes more than 2 seconds to go back, then it is a sign of severe dehydration. This skin pinch is assessed over the anterior abdominal wall. And we have to keep in mind that this sign or skin turgor or the skin pinch is flawed, and it is not a reliable sign if the patient is suffering from severe acute malnutrition. Because as it is, these children have considerable loss of subcutaneous fat, and therefore this sign is not reliable in the presence of SAM. In this case, we have to look at other signs, that is, the child is suffering from diarrhea, the child has altered consciousness, and the child has a decreased urine output. So these signs also have to be taken into account if we are dealing with a patient of SAM. In the absence of SAM, yes, we can assess by looking at the skin pinch. Now, assessing the skin pinch for a period of 2 seconds is a little difficult practically. So it is good to count in the mind any two numbers like 1001, 1002. If you finish counting 1001, 1002, and the skin pinch has still not gone back to normal, then this indicates that the skin pinch is delayed for more than 2 seconds. We look for the presence of fever, which also indicates that there is the presence of some infection, and meningitis. Meningitis is indicated either by neck stiffness or a bulging anterior fontanelle. In children, the anterior fontanelle usually closes around 1 to 1.5 years. So this examination is important in children who are less than 1 to 1.5 years of age. So the anterior fontanelle is examined here, somewhere around the crown of the head at the junction of the coronal and the sagittal sutures. If it is bulging and in the upright position, that is the bulging fontanelle, if we think that the fontanelle is bulging, then just raise the head of the child a little and examine it again. Even in the upright position, if the fontanelle is bulging, then it definitely indicates that there is increased intracranial pressure. So we look for these additional signs of pneumonia, severe dehydration, presence of fever, and meningitis. Now we have I have already explained in detail how to screen the child for severe acute malnutrition. Now, charts are available and we can plot their height, weight, length, and the Z scores and the standard deviations and Z scores on these charts, which will be available with you. Now, why height and length? Just a small clarification is that less than 2 years, we are looking at the length of the child, or if the child is bedridden, we are looking at the length of the child. Because measuring the length of the child requires some amount of cooperation from the child also. And above the age of 5 years, we are looking at the height of the child. Between 2 years to 5 years, it depends. We can take either height or length depending on how cooperative the child is. Now, let us look at the algorithm for assessment of CLHIV for advanced disease management. Now, particularly tuberculosis and overall the other danger signs that we have just discussed. Now, in a CLHIV who is less than 5 years of age, that is the advanced disease, We also do a 4S screening. This is as per the National Tuberculosis Elimination Program. That is a 4S plus 4S screening for tuberculosis. So what are these 4 S's? So first is the presence of cough, which is a more than 2 weeks duration, and it should be unremitting cough. That is a cough that is not remitting, or it is remaining with the same intensity for a period of more than 2 weeks. The presence of fever for more than 2 weeks. The presence of recent weight loss of more than 5%. This is possible only if we have a documented weight, previous documented weight, or if there is failure to gain weight in the last 3 months, in spite of giving proper good nutrition. Then these 3 criteria plus history of contact with a patient of tuberculosis is what we call as the 4S. If the patient is 4S plus, then this patient is referred to the medical officer. The medical officer screens the patient for tuberculosis. We shall come to the screening algorithm later, as well as looks for the presence of danger signs, as we have mentioned earlier. That is, a patient not able to take anything orally, vomiting, altered sensorium in the form of convulsions, lethargy, unconscious, or stridor. He looks for the signs of pneumonia, that is fast breathing, distressed chest indrawing, if the presence of dehydration is suspected, fever, or if there is any sign suggestive of meningitis. Then this patient definitely requires hospitalization and inpatient management for all these serious conditions. And this patient should be referred to a higher center for appropriate management. However, if none of these is present, then the child is also screened for SAM. We have already seen what are the criteria for SAM. I will not repeat it. So we look for the presence of SAM with associated complications, like the child is not taking orally, or any of the previous signs like dehydration, pneumonia, and the child is having some problem with breastfeeding. Then again, this is a child who requires inpatient hospitalization. However, if none of these serious issues are detected, then the medical officer, with or without consultation with the pediatrician, manages the patient. Right? A child who is only 5 years of age without any of the danger signs mentioned above, if the WHO clinical stage 3 or 4 CD4 count is less than 200 cells per cubic millimeter, or a low CD4 count less than 15%, or if there is unsuppressed viral load, he assesses the child for all these parameters. If all these are absent, then the child may be offered a standard care package. However, if any of these signs are present, that is the danger signs, or if there is tuberculosis, other active diseases, or if there's severe immunosuppression, then the child is given advanced disease management package. Now, majority is the same in both of them, except in the advanced disease management package, we are mostly going to be admitting the patient. We are going to be doing a more intensive investigation for infections, and we will be initiating ART rapidly. That is, rapid ART initiation is required. Now, we come back to screening for tuberculosis. Now, how do we screen for tuberculosis? In adults, it is relatively easier. In children, it's a little more complicated because multiple causes may be there. And again, even if the X-ray is suggestive, getting a good sputum sample in cases of children is a challenge. Right? So let us try our best and understand and decide what to do in each situation. So we would like to do intensive case finding of tuberculosis amongst CLHIV. That is the 4S screening. If these are there, then we stamp the child as having 4S plus, and then the child is referred for further investigation for the presence or absence of tuberculosis. So if 4S plus is there, then we would investigate for TB. How? First investigation of choice is we do an X-ray chest. If the X-ray chest is suggestive of tuberculosis or is showing any, like if there is the presence of hilar lymphadenopathy, parahilar nodes, something like the primary complex, the presence of maybe miliary tubercles in it, or there is the presence of a consolidation, which is likely to be tuberculosis, we have to do two things. First of all, we may give a course of antibiotics and see if the X-ray chest is improving or not. If it is not improving, then it is more likely to be tuberculous in nature. Now, one thing we have to keep in mind is that when we are treating this or we are giving this course of antibiotic to the children, we should make it a point not to use linezolid or fluco or any of the fluoroquinolones as a antibiotic course, because this will also cross-react, or they are also anti-tuberculous therapy. So these should not be used. So we give a course of antibiotics. In spite of that, if there is no change and no improvement in the X-ray chest, then we screen the child further for the presence of tuberculosis by trying to collect a specimen for TB. Now, what could this specimen be? In children, if pulmonary cox is the case, then algorithm, let's go next. Yeah. Yeah. So this is a list of all the investigations that we can do. Then we'll go back to the algorithm. I would like to discuss each of these investigations individually. So first is, of course, the clinical, that is a 4S evaluation, X-ray chest I have taken with you. Then let me discuss obtaining a sputum sample in children. So this is a challenge. Older children may be able to cooperate in bringing up a good, adequate sputum sample, but in younger children, it is a challenge. So how do we go about it? In a younger child around infancy, we would like to do a gastric aspirate on 2 occasions. 2 sputum samples are required in any case. So on 2 occasions, we do a gastric aspirate. This is best done in the morning. And if it is not possible to do it in the morning, then at least a 4 to 6 hour fasting should be done in all these children. So we send a gastric aspirate or lavage, and this should be sent after collection. It has to be stabilized with sodium bicarbonate, and it should be sent as early as possible to the laboratory for CB-NAT testing. In case the child is old and older than around 6 years and is able to bring up an adequate sputum, then a sputum sample, 2 sputum samples are sent for CB-NAT testing. If the child is younger, then we may attempt an induced sputum. That is the collection of the sputum after nebulization with 3% NaCl. And if the child is having some severe pneumonia, a bronchoalveolar lavage can also be done in the appropriate setting. So this sample is then sent for CB-NAT testing. However, we should remember that the yield and positivity, it varies and it is not very high. The yield is good from in children from pulmonary, good is around 30 to 50%. That is just about half, and it depends on the center and the quality of the sample collected. So it ranges from 30 to 50%, and the yield is still a little better for a pulmonary specimen as well as for CSF, or it is coming from pus. But in cases of pleural, the yield is extremely poor, or ascitic fluid, the yield is extremely poor. CSF, it is again, it depends on the center, but we can hope for around 30 to 40% positivity. So that is a challenge. So very often we still have to consult with the pediatrician and take a call on to whether this is likely to be tuberculosis or not. So either we could have a microbiologically confirmed case or a case which we have diagnosed clinically. In this case, if we are not able to isolate, it is better to consult with a pediatrician and make the diagnosis. Another modality for testing is the tuberculin skin test or the Mantoux test. Now, the standardized is 2TU RT23, which is a little difficult to procure. And we should make sure that it is 2TU. Certain studies are mentioning that up to 5 TU is acceptable, but standard literature is mentioning 2 TU. So as we go up onto the higher TUs of 5 to 10, the incidence of false positive results increases, and therefore it is not considered to be a standardized report. So this may be tried, and in cases of HIV, we consider a cutoff of 5 millimeters of induration, not erythema, induration of 5 millimeters, and it is read between the 48 to 72 hours after injection, right? So this is an adjunct, and it does not clearly distinguish between the presence of an active infection or exposure to infection. But yes, it just contributes to our diagnosis. So in cases of normal children, we take a cutoff of 10 millimeters as positive of induration. Let me again stress that of induration. In cases of HIV, even more than 5 millimeters is considered as significant. Again, I would like to emphasize that it should be taken at right angles to the vertical axis of the arm, right? So in just one axis, and that is horizontal axis at right angles to the vertical axis of the arm. We can look for tuberculosis at other extrapulmonary sites, that is ultrasonography for abdominal tuberculosis. If there are lymph nodes palpable, we can go in for an FNAC of the lymph node. If an FNAC is inconclusive, then we can go in for excision biopsy of the lymph node. And if possible, then pleural and ascitic fluid can also be sent for cytology. Of course, for neuroimaging, we are using neuroimaging for CNS tuberculosis, and we look for suggestive features like the presence of a tuberculoma, basal meningitis, etc. Okay, so right. So pulmonary tuberculosis, we have seen the 4S. Extrapulmonary, we can even ask for other symptoms like brain TB may be coming to you with additional symptoms of headache and confusion, backache, joint pain, or a spinal deformity in cases of bone TB, chest pain, tightness in the chest, respiratory distress, where we have to suspect pleural or pericardial effusions, or hepatosplenomegaly, abdominal pain, abdominal lump, diarrhea, etc. in case of abdominal tuberculosis. And we always keep in mind contact with a tuberculous case. So 4S is for pulmonary, and these are the features for extrapulmonary. Yeah. So we are looking for we are suspecting tuberculosis if we find that in our 2 sputum samples, if any one is positive and the X-ray is suggestive, then it is a microbiologically confirmed case of tuberculosis. If not, if the X-ray is still suggestive, then we take it as a clinical case, clinically diagnosed case of tuberculosis, and we start the patient on anti-tuberculous therapy. If we feel that this is not tuberculosis, then we follow up, assess, and we consider isoniazid preventive therapy if there are no other contraindications. And we also consider other diagnoses if we are not thinking of tuberculosis and give appropriate treatment. In these cases also, we can consider giving isoniazid preventive therapy if there are no contraindications. Now we have to always look for other causes also and any overlap, because we have bronchiectasis, lymphoid interstitial pneumonias, so LIP. So all these things have also to be kept in mind when we interpret an X-ray for pulmonary tuberculosis. So if we are not considering TB or other diseases, we assess the patient for any contraindication to isoniazid preventive therapy. If it is none, then we would definitely put this patient on preventive therapy. If there is some contraindication, then we defer the IPT. Now we have to remember that this screening for tuberculosis has to be done regularly and at each encounter with a health worker or a visit to any health facility. Now, this is cryptococcal. So the main difference, like I have said, is we are not doing routine cryptococcal. So screening in children who are less than 10 years of age, because it is not that common. We do it only if a child is more than 10 years of age. However, if a child less than 10 years of age presents with signs and symptoms of meningitis, then we should consider cryptococcal meningitis and send appropriate investigations. Okay. Now we come to the treatment of tuberculosis in CLHIV. Now, before I launch into the treatment of tuberculosis, again, I would like to emphasize that apart from all this screening and this danger sign assessment, looking for pneumonia and diarrhea and cryptococcal, do not forget to look for other micronutrient deficiencies, that is anemia, B12, and other multivitamins, vitamin D. So all this has also to be kept in mind. And so this, as well as growth monitoring and nutritional counseling, has to be done at each and every visit. Now, the treatment of tuberculosis in children has to be done according to the NTEP guidelines. That is, we have one category mainly in the first line, that is where we are giving 2 months of isoniazid, rifampicin, ethambutol, and pyrazinamide, followed by 4 months of isoniazid, rifampicin, and ethambutol. So the intensive phase is 2 months and 4 months of the 3-drug continuation with isoniazid, rifampicin, and ethambutol. In cases of CNS tuberculosis or in cases of bone TB, the continuation phase is for a total of 1 year. That is, the total duration is 1 year, and the continuation phase is therefore for 10 months. Okay, so a daily dose is given of isoniazid of under this program of 10 mg per kg with a maximum of 300 milligrams. Rifampicin is 15 milligram per kilogram, maximum of 600 milligrams. Ethambutol is 20 mg per kg, maximum of 1500, and pyrazinamide is 35 with a maximum of 2000 milligrams. So these are the weight bands and the daily dosage schedule for pediatric patients up to the age of 18 years as per the weight band. Now, when we are dealing with weight bands, all of you are aware. So not telling you nothing new, but just reinforcing that we expect a good response and a good weight gain once we are initiating the child on anti-tuberculous therapy and we begin the total treatment and rehabilitation. So do not forget to change the dosage according to the change in the weight band. So the change in weight band has to be checked every time, and with a change in the weight band the dosage has to be changed accordingly. Okay. Now we are all aware of the regimens that are to be used in CLHIV. So in this, we will deal with what changes to make in cases of drug-sensitive tuberculosis. Now, if we are able to get a CBNAT, then we may be able to check whether the sensitivity to the drug is there or not. If not, then we have to follow up the child clinically and look for the response. Now, in cases of a child who is less than 20 kg, or if the age is less than 6 years, this child is likely to be on an FDC of abacavir and lamivudine twice daily as per the weight band, plus lopinavir, ritonavir. So we do super boosting with additional ritonavir twice daily as per the weight band. Between 20 to 30 kg or 6 to 10 years, we continue with the abacavir and lamivudine twice daily as per the weight band, but we increase the dose of DTG 50 milligrams to twice daily instead of once daily. And if more than 30 kgs and an age above 10 years, then we give tenofovir plus lamivudine plus DTG once daily, again with an additional dose of dolutegravir 50 milligrams DTG, again after 12 hours. So we should keep a gap of 12 hours between the morning FDC and the evening dose of DTG. What we should not forget is that the DTG or the lopinavir, ritonavir super boosted, it should be continued in this additional dose or in the super boosted for 2 weeks after stopping the anti-tuberculous therapy also. That is, after we finish the course of AKT, 2 weeks additional, we will continue with this extra DTG and super boosting of lopinavir, ritonavir. I will not go much into this slide, deals mainly with adults. This we have already covered. Okay. Now, just a short note on management of HIV, TB co-infection in certain specific situations like pregnant and lactating women. So all of them are safe. All the primary drugs of HRZE are safe during pregnancy and lactation. But second line anti-tuberculous therapy, that is amikacin and streptomycin, are contraindicated because they are ototoxic and they damage the 8th cranial nerve of the fetus. Fluoroquinolone can affect the cartilage development of the fetus and therefore has to be avoided. Ethionamide is contraindicated in the first 32 weeks because it is teratogenic. Bedaquiline and delamanate are also avoided, best avoided, because we don't have adequate evidence on their safety. Shorter oral bedaquiline containing MDR or RRTB regimen cannot be administered during pregnancy with DRTB. And amongst the antiretroviral therapies, DTG efavirenz containing regimens are safe in pregnant women, but they have the freedom or they can exercise an opt-out option for DTG. So we have seen the screening, we have seen the treatment, and now we come to the optimize and prevent aspects of stop AIDS. Now, if the child is having in the advanced disease package, like we have said in optimization of therapy, we would like to do rapid ART initiation within 7 days of diagnosis. Children who require hospitalization, they always need to be clinically stabilized. Like we all know that a child is more likely to die of the opportunistic infections and the other life-threatening infections than ART. So ART has to be, rapid initiation of ART has to be done, but we should not neglect the other life-threatening infections, and they have to be clinically stabilized before. So during the hospital stay itself, we would like to encourage and initiate the ART as well as ensure linkage to the facility in which the child will receive ongoing HIV care after discharge. And that is absolutely critical that we do that. Now, the second, after optimization, the last is we come to is prevention, not second, the last is prevention. So we all know that in the preventive therapy, we will deal mainly with two. One is the cotrimoxazole preventive therapy. I will not go much into detail because all of you are already aware. That is all HIV exposed infants and children from 6 weeks onwards. They receive it until we definitely rule out HIV infection. So a minimum of 18 months. If they turn out to be HIV infected, then this has to be continued up till the age of 5 years. And this is irrespective of what the WHO clinical staging or the CD4 counts are. So up till 5 years, we will be continuing it without fail, because we want to cover this period maximum morbidity mortality. At 5 years of age, we can reassess. If the child is clinically stable, immunologically stable, that is, the immune system is restored and working just fine, we have to check on 2 occasions, 6 months apart. And the child is stable, stage 1 or 2, good immune status, then we can consider omission of the cotrimoxazole prophylaxis. If the child is greater than 5 years, again, if stage 3 and 4, and irrespective of CD4 count, or if there is CD4 count is less than 350, we are going to start CPT and we are going to continue it till the child has good immune restoration. For more than 6 months, then we can consider omission of the cotrimoxazole. We may also be giving cotrimoxazole as secondary prophylaxis if we are treating the child for PCP pneumonia. We follow the same guidelines. If the child is less than 5, we continue till 5, reassess. If the child is more than 5, we continue till there is good immune restoration. So this is the dose of cotrimoxazole, that is 5 milligrams per kilogram per day, once a day has to be given. We may either give syrup or tablet. Now, we do not recommend making quarters of the tablet, so that should be kept in mind. Now, we have to emphasize to the caregivers that this CPT, which is going daily, is not a part of the antiretroviral therapy. And although it is absolutely essential, it is not going to be treating or curing the HIV infection. And we should also monitor the child for any adverse effects. That is SJ syndrome, liver disease, severe liver disease, anemia, or pancytopenia. If any of these adverse reactions come up during cotrimoxazole therapy, we have to consider omission of the CPT prophylaxis, or if we have excluded HIV infection. Now, the second preventive therapy that we are giving in these patients is isoniazid preventive therapy. That is, all CLHIV who are more than 12 years of age, they first have to be screened for the presence of tuberculosis. That is absolutely essential. We cannot start IPT without screening the child for tuberculosis, active tuberculosis disease. So all efforts have to be made to first find out if the child is suffering from the disease, right? So we follow the entire algorithm. We try our best to diagnose. We consult with pediatrician if required, and then decide whether the child is having active disease or not. If the child is not having active disease, then we will consider IPT, provided there are no contraindications to the same. So more than 12 months of age, all children in whom we have ruled out active tuberculosis, we will be treating with IPT, that is isoniazid preventive therapy, in the dose of 10 milligram per kilogram per day for a period of 6 months. Again, what are the contraindications to ITP? Active TB, if there is active hepatitis, peripheral neuropathy, other hepatotoxic medications are going on, we are suspecting MDR TB, or a PLHIV who have completed drug-resistant tuberculosis treatment. We should supplement pyridoxine to all children who are undergoing ATT, and preferably all children who are also undergoing IPT. So this, with this, I come to the end of this session. I look forward to your questions. I hope I have been helpful in solving some of your queries. And if there is any questions, please go ahead and ask them.
Thank you so much, ma'am. Participants are requested to please unmute themselves. They can ask questions or they can type in the chat box. Any questions from the participants?
If there are no questions, either the lecture was very good or everybody has zoned out.
No, ma'am, it was very good. Thank you, ma'am.
I hope it wasn't the latter.
No, ma'am, no. Ma'am, I don't think there are any questions. Can we quickly run the feedback form, ma'am? Kiran sir, can we have the feedback form, please? Yeah. The feedback poll is now visible on your screen. There are 4 questions in all. Please answer all the 4 questions. The post-test link will be shared with you by today, 5:30 p.m. Please attempt the post-test by 3 p.m. tomorrow. Any questions from the participants? Please unmute your mic. Requesting all the participants to please attempt the feedback poll. The next RDLS session is on 2nd of March from 2 p.m. to 3 p.m. and the topic is care of CLHIV post-ART initiation. For this topic, you can refer to chapter number 3.4 of the National Guidelines for ART Care and Treatment. Thank you so much, ma'am, for facilitating this session. Thank you to all the participants for patient listening. Ma'am, can we conclude the session now? Thank you, ma'am.